and welcome to another episode of Real Talk on Renal Cancer. My name is Laura Esfeller, and this is your monthly podcast from the Judy Nicholson Kidney Cancer Foundation. We're very grateful for the support that we receive for this podcast from Exelixis, Ipsen, and Merck. And today I am really excited and thrilled to welcome to the podcast Tracie Titus. Welcome, Tracie.
Thanks, Laura. Thanks for having me.
Thank you. For our listeners, Tracie and I have known each other for quite a while now, a few years, but I know that many of you are probably not familiar with Tracie and her story. So, Tracie, if you don't mind sharing about you and your connection to kidney cancer.
Sure, thanks. Yeah, so we met actually 4 years ago when my husband was diagnosed with renal cell carcinoma. So I'll kind of channel our story and how we got there and how it's very full circle to be here with you because you were such an important part very early on. But my husband, we saw a new primary care, and my husband had a history of high blood pressure, and she said, "Let's just do an echocardiogram just to see." And so we did that, and the echocardiogram actually showed a very large aortic root aneurysm, which is a very serious diagnosis. And we were kind of immediately seen by a cardiothoracic surgeon who did additional testing. And the good news was that the aneurysm was not quite surgical yet. The additional testing that they did in the chest caught the top of the kidneys. And that's when they saw multiple tumors in both kidneys. So then we moved on to a kidney workup, and that involved the big thing about my husband's case that was so surprising was the number of tumors that were seen, as well as the fact that they were in both kidneys. So that's called bilateral, both kidneys, multifocal, multiple tumors. So it really puzzled everyone about what this could be. And, it was going down the path of, could it be a kidney disease like polycystic kidney disease? Is it some sort of genetic disease that causes multiple tumors, like HLRCC, like VHL? So there were a lot of questions and a lot of tests. When you have that many tumors in the kidney, they're concerned about spread, certainly outside. And so we did all of that testing, and it was confined to the kidneys. And so we then were told that our only option was to remove both of his kidneys and have a bilateral nephrectomy and go on dialysis. And at the time, my husband was 39 years old, and I had spent 20 years working in healthcare. And ironically, my father was born with a kidney disease and had a kidney transplant the year prior. So I was very familiar with what life on dialysis could be like. And I started to get the feeling that what he had was unusual, just by kind of the surprise over it. And so I thought, and I was trying to research as one does, and it was really hard to find any information about what he had. It just didn't seem to be out there. And so when you have a cancer diagnosis, like, you are desperately longing to find someone who has what you have, like, because you feel so isolated and so alone. And so, I went and started searching for groups on Facebook, and found a Facebook group with Casey Cure, and I posted our story. And it didn't get a lot of responses, I think, because it was so rare. But you, my dear friend, was the first person who responded, and you said, that is very rare. I wouldn't take out his kidneys until you get another opinion. And at the time, we were at a major academic medical center. We were where people go for a second opinion. So that was kind of a little jarring. And then you said, I think you need to get to the NIH, which is the National Institute of Health, or the National Cancer Institute in Bethesda, Maryland. And at the time, I didn't know that the NIH actually had, like, I just thought of them as like a research hospital. And so you then said, I'm going to see if we can connect you to Dina Battle, who can maybe help to get you into the NIH. And so very quickly, I spoke with Dina, and she was able to get us to the NIH, and we had a consult with them. And but in between that time, we had gone to the surgeon. We had gone to a dialysis clinic. We had gone to a to start education, to start the process. We had a final consult with the surgeon, and there was something in me that just thought to ask, how many times have you seen kidneys like these? And he said, never. And that's when I knew that we were not in the right place. And so through the advocacy group, getting to the NIH, and we got there. This was all during the height of COVID, of course. So that was tricky. And we drove and we got there, and they did their own testing and said, I think we can save one or both of your kidneys. And oh, we know exactly what this is. So my husband was officially diagnosed with bilateral multifocal papillary renal cell carcinoma. Back then, it was typed into a type 1, which is kind of the least aggressive papillary type. And he had 2 partial nephrectomies. They did one kidney first, and they removed 22 tumors. 6 weeks later, they did another partial nephrectomy. They removed 19 tumors. And both surgeries resulted in no loss of kidney function at all. Yeah. So we then we learned about his illness a bit more, his disease. And most people, my husband was 39 when he was diagnosed. Most of the time, if you're that young and you have that many tumors and it's bilateral, they tend to think that there's a genetic component and something hereditary. And he does not have any hereditary disease. His is called sporadic genetic mutation. And they know what it is, and they have other people who have it, but they don't know what gene is mutating that to cause that. So we do know that as long as he has his kidneys, the tumors will continue to grow back, although they are quite indolent and they grow slowly. In fact, they estimate that he could have had them for 20 years without knowing, no symptoms. So we then we're in like an active surveillance. So the way that this is treated is to monitor. So we were going every 3 months initially, then every 6 months. And essentially, when they did the initial partial, they removed all the largest tumors. He had one that was 6 centimeters. That was the largest, but everything else was like 3 or 4 centimeters. And then he had a bunch of what they call baby tumors. So there were so many that all the tumors couldn't be removed. And so we've been watching and waiting on those. And the threshold is 3 centimeters. Once a tumor reaches 3 centimeters, then they start wanting to talk about taking it out because of the potential to metastasize outside of the kidney once it gets greater than 4 centimeters. So a year ago, my husband had a 3rd partial nephrectomy, a 2nd on one kidney, and all of the tumors were removed from that kidney. So that kidney 1 year later is still completely clean, which is very exciting. His other kidney does have some tumors remaining from the first surgery, and we actually just learned that he will need another partial nephrectomy next month with the goal of hopefully removing all of those as well.
Tracie, as you mentioned, I know your story well, but it still gives me chills to think about because, to your point, your husband was so young and also like in great health and, and everything, right? I mean,
right, no symptoms.
Right,
Yeah.
no symptoms and everything. And to have this, come out of the blue like this, I know was very, I don't put words in your mouth, but just in conversations we've had, right? It was very shocking. And, and I really appreciate what you said about the fact that whenever you have something so rare, you just want to talk to other people who also have gone through this. But, to your point, I don't, there's not a lot of documented cases of multifocal papillary, compared to bilateral papillary, compared to some of the other kidney cancer types, right? I mean, I think that you've done some of your own case studies since his diagnosis, but the number is quite small, I believe, correct?
It is, yeah. I think the NIH has maybe 80 or so people in this trial. And he presented about 15 years earlier with a
Wow.
much higher tumor burden. than
Wow.
other patients. So there's
Right.
something kind of extra unique about him.
Yeah.
And yeah, but we're not sure what it is, but he's contributed at this point. They've removed over 50 tumors from his
Wow.
kidneys with no loss of kidney function. So he's contributed a lot of tissue
Yes.
to identify what the gene is. Yeah, that's mutating.
Well, we appreciate that
Yeah,
as
yeah,
a
yeah.
community, because I think it helps, answer questions that down the line. I mean, we've talked on this podcast before about how after ASCO earlier this year that we believe that there might be now a biomarker for kidney cancer, which is just scratching the surface of what is potentially to come. But whenever patients like your husband and myself donate our tissue, it really can, really, it can lead to breakthroughs that we don't see right now, and
Um,
so thank you for that.
Yeah, and I think that there's a misnomer about, being treated at the NIH. People think of it as like a research hospital and, everyone at the NIH is on a clinical trial. That's true. But in his case, it's really just a surgical tissue trial.
Right,
So, you're getting treated like you would anywhere else, but with people who like this is what they do.
right,
The NIH is known for their ability to remove multiple tumors from kidneys
yeah,
and not lose them, which is really critical with
right.
this type.
Um, you know, I feel like we don't talk a lot in this space about bilateral kidney cancer, and this is something that I hear concerns about from patients and caregivers, especially if they're stage 4. They worry, okay, I've had a nephrectomy, a radical nephrectomy. What happens if I, get kidney cancer in my other my remaining kidney, right? And so, are there any kind of differences that you've noticed being a caregiver to your husband that is different whenever you were dealing with bilateral kidney cancer as opposed to, it being in one?
Yeah, I think it's very different actually, and that's why I think it was so hard to find other people who have had this. And you know, when you're diagnosed with cancer, I think the first thing that anyone thinks is get it out, get it out, and they think reasonably, I don't want to leave any of my kidney back. Like, what if they leave any part? It's better to just take the whole kidney. And I think that that's a misconception that remains. And what happens is people have full nephrectomies. They take out their entire kidney for like a 2 centimeter tumor, and now you're left with just one kidney. And bilateral is rare. But other things can happen in your life, right, that can impact kidney function. So with bilateral and multifocal, I will say, because tumors that are multifocal, and what that means, okay, it's not that my husband didn't have one tumor that then spread. They're all considered primary tumors. And so tumors that are bilateral or multifocal so multifocal tumors are more likely to be bilateral tumors are more likely to be multifocal. So the name of the game is renal preservation. It's kidney preservation with this, and it is really a long game. In removing the tumors once they reach a certain size, I think needing to be very comfortable with active surveillance is another thing that is different for bilateral multifocal, because we know that those tumors in small sizes, and I'm speaking of papillary, clear cell is different. There is clear cell bilateral multifocal. It's also rare, but specifically for papillary, it's an indolent cancer. It is unlikely to spread outside the kidneys when it's small, and so you've got to get comfortable with active surveillance, and that's a hard thing to do. We had to do active surveillance for not only the kidney cancer, but also for a very large aortic root aneurysm, which we were watching as well. So, normally active surveillance is sort of not me as a person. I tend to be like, oh, we have a problem, like, let's fix it. And the universe was like, you're going to do this twice, and you're going to do it for something big, and you're going to be comfortable with it, is how it's going to work. And My husband is very laid back and tends to be very focused in the present, not so much on what's coming or what has happened. So he, I think, dealt with it almost better than I did. So I think renal preservation is key. Whenever people have bilateral or multifocal tumors, you have to be thinking about saving your kidneys as much as possible for as long as possible. And then I think the comfort level with active surveillance is it's hard psychologically, and I think that is also something that is different. And I think even if you don't have bilateral multifocal, there's a lesson here too. Like, you don't have to lose your whole kidney. You can just have a tumor removed, and having a partial nephrectomy versus a full nephrectomy does not change the likelihood of recurrence, right? So I think, my mantra, like the joke is like, these are not, you don't have a second kidney because it's a spare. Like, you need them, and you want to keep them as long as you can, when possible, depending on the case.
Yeah, I so many nuggets that I want to touch on with what you just said, because I think to your very valid point, it is larger than just for bilateral multifocal papillary patients, right? Active surveillance is a common topic and a source of anxiety for a lot of people within the kidney cancer community, right? On top of that, I do think that you bring up a very, very valid point that we don't talk about enough in the community, that renal preservation and renal function preservation is also important. Like, yes, removing the cancer is important, whether you're removing the cancer through surgery or through systemic therapy or radiation, right, what have you, right? But there is something to be said for making sure that you still have a functioning, kidney function, right? Like, that you aren't going to have to go on dialysis, which is, obviously I'm glad that it exists for the people who need it, but it's not a walk in the park. And having, solid kidney function is really important. And I think that, as you mentioned, like for me, and I've shared this on the podcast before, my tumor burden on my right kidney was very large, and it basically had engulfed the kidney, and I had a lot of other complications that there was no way that I could have done a partial
You couldn't have
nephrectomy,
saved it,
right?
yeah. And
Yeah,
sometimes it's not possible,
right.
right?
But
Mm.
I think that, especially as the field has changed over the last, I would say 5 years in particular, where now, we're not necessarily rushing everybody to surgery. Now there's, you can do adjuvant treatment, or, you can do neoadjuvant treatment. And a lot of people are being put on systemic therapies before they're being sent to the urologist for surgery. I think that, it's important for us to talk more about how, do you really want to weigh the difference between having a radical nephrectomy, to your point, for a smaller tumor that maybe could be saved partially, versus, the kidney function that you're going to lose by losing a kidney. So
Right.
thank you for bringing that up. I don't think we talk about that enough in the community.
Yeah. Yeah, it's important, especially with bilateral multifocal, because
Right.
you already know that you have the potential. But I think, the standard of care is moving toward active surveillance for small
Right.
renal masses under 3 centimeters. And
Yeah.
so I think patients more and more will need to feel comfortable with inaction, basically, right?
Yeah.
It's not taking it out. And I would argue that active surveillance is still doing something, but
Right.
it's not as, as big as like taking it out. And I think
Right.
I think through the advocacy efforts that you do, that I do, that we all do, it's like it's helping people understand that, like, it's okay. Studies show that under 3 centimeters, small renal masses, you do not have to rush to surgery.
Right.
But you do want to stay on top of them, right, through active surveillance. So I think that and the psychological burden around that, I think, is going to be big for this community and needs to be addressed.
I completely agree. I wanted to touch on, you shared how you and your husband actually started at a large, academic center that had given you one piece of advice on how to handle his case. Then you went to NIH for your second opinion, which completely changed his treatment plan. And, to me, that touches on a topic that I think is really important about shared decision making. And so maybe if you can share your perspective on why shared decision making is so important with kidney cancer patients, and how can their caregivers help with that? How can they be a part of that process?
Yeah, so shared decision making is always a buzzword, in the industry, but basically the idea is that patients need to be made aware of all options and the risks and benefits of all of those options. And so that's around having a very open dialogue with whoever the provider is about that. I don't know how often shared decision making happens, if I'm being honest. And I think often patients are uncomfortable asking questions because it seems as though you're questioning the expert. But it's really an important piece, and I think if I think back to our time, if I hadn't asked the question, how many times have you seen kidneys like these, and got an answer of never, I don't know what would have happened, right? And I think and I think I asked that question because I understood what the risks of dialysis were, particularly for a young person who would have zero kidney function. Most people on dialysis have maybe 10% kidney function. In my husband's case, he would have had zero, which means longer treatment. He's also a big guy. That means longer treatment, inability to work. I mean, the quality of life, cardiovascular risks are like increased by like 40% for people on dialysis. I mean, there are so many risks to it. Now, of course, if you don't have kidneys or you have a kidney disease, you have to do what you have to do. But I think that when so my own knowledge helped with the shared decision making, because again, I think when you have cancer, the first thing that you want is to get it, period. I think regardless of what kind of cancer, you just want it. And so you are likely to move in that direction. You know, one of the things that a friend of mine will say is, when her husband was diagnosed and they moved quite quickly to a nephrectomy in the ER, she said, I was just so shocked and scared that, if they had told me to drink gas, I would have asked them if 87 was okay, so I think like it is so scary. And so I think that, so my knowledge, I think, helped to supplement the shared decision making, because I don't know that we really had that. If I'm being honest, we were kind of told like, how quickly should we do this, and we were told yesterday. So then when we went to the NIH and got a second opinion, I expressed my concerns around dialysis and about saving kidney function, and so we talked a lot about that. I expressed my concerns around active surveillance. I asked, what are the percentages of metastasis based on certain size? And so we were able to kind of have that dialogue. And I think as patients and as caregivers, right? Because sometimes, not everyone has that in them, right? And so in our relationship, that is more of me. And because of my healthcare knowledge, that certainly helps. What you think and what you want matters. It matters in the decision that you make together for your treatment plan. And that's something that you should talk to your physician about, and your provider, because it's your choice ultimately. Now, of course, we take the opinion of experts, and like that's why we're seeing them. And so, likely you follow. But if you say, I'm concerned about renal preservation, I'm concerned, that's a conversation that you should have to either validate that concern or learn more information that tells you why. Just like we were concerned about active surveillance, but then understanding, no one with my husband's type of cancer has had it metastasized if it's less than like 4 centimeters. So right away, that just changed the lens. So I think pushing for that as either a patient or a caregiver, is important to make sure that you end up with a treatment and a plan that you're comfortable with and that everyone's comfortable with, and really understanding what your options are and the risks and benefits.
I completely agree. And, I was thinking too about the importance of, really making sure that you're getting all the knowledge that you can as you're making these crucial decisions. And what I mean by that is, I think Tracie, you and I are at the point now, and we were talking about this a little bit before the podcast about how, the decisions that we make now, after being a few years down the road in this journey is probably different than, or it's definitely different, at least for me, and I'm sure for you too, right? Than my instinct would have been when I was diagnosed 8 years ago, right? And part of that is because of the conversations and the connections that I started to build early on in the kidney cancer advocate community, right? So, and that's not to say, we don't want you to get medical advice from Facebook
So
groups or,
medical advice is good,
our
but from
patient.
doctors, not from,
Right,
right, those of us who are not. But you're
right,
right,
right.
we've been around
Yeah,
and we've
right.
seen things and we've
Yeah.
learned, and
Yeah, exactly. And so, so definitely not advocating for you to, find your next surgeon on Facebook, right? But, finding resources, credible, valuable resources where you can, I think is so important in the decision-making process too, because, again, like I have picked up knowledge along the way from my doctors, from other advocates in the community and all of that, definitely have helped me to at least point me in the right direction, right? And what I mean by that is, if I am concerned about something on a scan and I talk with my oncologist and I want to learn more about it, I'm going to go onto PubMed now. I'm going to read some papers about it. I'm going to maybe read a case study, that kind of thing, right? And I think that it's important that we make that less scary for people, like I always
yeah,
say, I'm not a doctor. I didn't go to medical school. I got my degree in liberal arts. So definitely not
right,
anything,
right.
healthcare or scientific related, but I don't feel intimidated anymore by going online, reading a paper and bringing it to my oncologist and saying, what do you think about this? And is there something that maybe could correlate to, my
Yeah.
treatment?
I think that's perfect. And I think the longer, you're right, the longer that we're in this, the more we understand and the more we can seek out that kind of information. I know this is like a perfect story of shared decision making. When we were at the NIH for my husband's first surgery, we were there over a weekend, kind of because surgery was on Monday, so they'd admit you early. It was COVID time too, and we were sitting there on the weekend, and um, in on a Sunday walks Dr. Marston Linehan, and Dr. Linehan is the head of the urologic oncology branch at the NIH. He's very, very well known, and I had stalked him obviously online, so I knew who he was, and I was sort of like in awe. And in she comes, and I'm like, what is he doing here? Because I didn't know that he still rounded on patients, and he was on call that weekend, so he came by just to introduce himself. Um, and I used the opportunity to talk to him and to learn as much as I could. And that gentleman sat there and answered all of my questions and gave me so much information. And then I said, I've been searching online and I just can't find anything related to his subtype. And he said, "Oh, I can give you some info. Let me see what I can find." So I said, "Okay." And then we said our goodbyes. And later that evening, Dr. Linehan came back with a stack of articles that they had written about Branson subtype. And so he knew that I wanted information and he was willing to sit there on a weekend. And then the man came back with that so that I could learn more. And that to me is a perfect example of shared decision making. And it's also a great story of just how wonderful the NIH is and how grateful we are to be there.
I love that story. And
Yeah.
I'm not surprised also knowing how Dr. Linehan is. And I think it also just speaks to the community of doctors that we have, that, I feel very privileged to know a lot of the, oncologists and neurologists that are in the community, and, their passion and their dedication to their patients and caregivers is really just incredible to see. And I'm always humbled by it because, they really do dedicate their lives to
Yeah.
something that in most cases hasn't impacted them personally, right? It's not, sometimes there are cases where maybe they had a family member who had a genitourinary cancer, but most time it's just they, kind of fell into that part of the field and really, are doing it just because of, the work that they love, the work that they do. So
Right. Right.
really incredible. Tracie, I wanted to ask you, what tips do you have? Because we do have this podcast is mainly focused for patients and their caregivers. What are some tips that you have for other caregivers as far as not just advocating for their patients, their loved ones, but also how do you take care of yourself whenever, this disease has not just impacted your husband, it's impacted your life and changed your life too. So
Yeah.
how do you take care of yourself and, in these times?
Yeah. I think being a caregiver is hard. And it's hard for so many reasons. It's hard to watch the person that you love go through surgeries, or whether it's systemic treatment or whatever they're going through. That's really hard to watch them in pain and suffering. It's really difficult. And then, there's that part. But I think one of the things that is often overlooked, I think, and not talked about a lot, is while the focus is obviously on the patient with the cancer, it's, as a caregiver, it's like I almost feel like I have cancer too. And I know that I don't, and I'm not trying to minimize the impact of that. But it's not just the patient going through it. You are walking with them through all of it, but then you're also keeping the house running and doing the grocery shopping and working, likely, right? Because they are not able to work. And so you've got, the heaviness of the illness, and the treatment for that, and the uncertainty that is around it. And then you're also trying to live like your everyday life, right? And no one asks how you are. And that's okay, because they're focused on the patient, which of course, like, we all want. And so my advice is to really kind of take a minute and focus on how you are. Because, one of the things for me is I'm very much like getting stuff done. And so I'm scheduling surgeries, I'm doing all that stuff. And then if someone just stops and says, like, but how are you? How are you? Then you kind of get connected to more to your feelings, right? Because so I think for me, finding other caregivers um, that are has been helpful, particularly, finding other women who are caring for their husbands. Like, there is an immediate connection there that like. I don't know how to describe to you, but the few instances where I've met a caregiver, a wife taking care of her husband, there's just this connection. In fact, just when we were at the NIH last week, we're sitting in an MRI, which is freezing. Pro tip: wear a jacket. And the seated next to us was another patient and his wife, who had VHL. And interestingly enough, VHL also has bilateral multifocal tumors. And so treatment is similar. And so they even need more surgeries because the tumors are kind of in multiple places, brain, et cetera. And as we just started connecting, it was this immediate, like, I get you. I get you. And there's something very, very strong in that. So my advice is to try to find a caregiver. And you can do that through Facebook groups. Sometimes you're sitting in a waiting room, and really also check in on you and taking care of you. Because this is cliche, but if you don't take care of you, you will not be able to take care of the person that you're caregiving for. So whatever that looks like for you, whether it's, going for a walk or playing with your dog or talking to a friend or whatever it is. And I think it's also okay, for a long time, I didn't want to kind of admit that I was struggling because I just didn't want the focus to be on me. It needed to be on him. But I think it's okay to say, like, this is hard for everyone, and it's hard for you too. And whatever resources you need, whether it's, therapy or whatever is going to work for you is important, and take advantage of the programs that they have at most academic medical centers have some sort of social work program. They often have like, groups. Take advantage of the services, because it's not an easy road, and whatever help you can get um, is important.
Yeah, I agree. And, I think that the point that you bring up that, a lot of times the caregiver is struggling with, not even a lot of time, I think all the time, the caregiver is struggling with not just, the physical aspects of caregiving, right? But also the mental and emotional aspects too. And, yeah, people are usually saying, well, how's your husband doing? How's he feeling? And we should be more mindful as a community of saying, how are you doing? How are you
Yeah.
holding up,
And it
and
feels even weird to say, because you're like, no, like he has cancer. I don't have cancer. But it is, I read someone called it like a co-survivor. Like you both
yeah,
survive the trauma of that. And
right.
I totally agree with that. And I think in the beginning, like I didn't really even understand. And another kind of the story when Branson, I think I use his name, but my dear sweet husband Branson, when he went in for his first surgery, there was so much to get us there, right? I mean, we told the story, right? And it was all in like a span of like 6 weeks. And so in the height of COVID is like, and we're at and I'm like, fine. I'm like, no, I'm good. I'm getting it all done. And so I'm in the pre-op with him and all the doctors and nurses, and they're doing kind of their final thing that they do before they take him in the back. And all of a sudden, I just sort of felt this like, I'm, I think I'm going to lose it now. Like I could, and the tears started coming. And a nurse anesthetist was behind me. And I think he started to see what was happening. And he put his hand on my shoulder and he whispered in my ear and he said, it's proof for you now. Wow. And so, because he saw that I was going to lose it. And that man kind of very calmly moved me sort of away. They were taking my husband and he moved me to the corner. And as I went around, my body actually sort of like collapsed in half. And I just, with tears, and it was sobbing, very ugly, sort of crying. And he just let me have that. And that man hugged me for a solid 5 minutes. And um, I was just, everything had just come out because see, at that point, I had done everything I could do. And now I just had to wait. There was nothing else that I could do. And kind of losing that control after driving the ship or whatever for so intently to then just be like, now I just sit here and wait. I don't think I realized how impacted I was. And the kindness of him, that's my other tip. Accept the kindness that you get from people because you will get it and you will be completely floored and overwhelmed by the kindness that you will see from other people. Accept it, hold it in, because that's what's going to get you through that time. Um, Check in with yourself because often you just don't even realize it.
Yeah. I like want to hug that that nurse.
I look for him every time I go.
Yeah, I know. And I think I think I've shared this on podcast before, but my mom had kidney cancer, and Tracie, this, I've shared this with you before, but I often say that I think for me that was worse than my own diagnosis and treatment and everything because I knew enough at that point to be dangerous, and I felt the same way, right? It was like I'm doing all these things to make sure she's seeing the top doctors and she's, getting in with this particular specialist and on this treatment and everything. And then then you get to the point where you're just like, there's nothing more I can do. And I am a control freak. I've admitted that before
Yeah, no,
here,
yeah. I mean, I think
right?
we've
And
established I
that's
am as well,
scary,
sure.
right? Just be
It's the
like, there's
surrender. It's
the
the surrender.
surrender. Yeah.
And that is it, yeah. And that's the fact that gentleman in that moment saw what was happening. And
Right.
I had held it together for my husband because I didn't want
Sure.
him to think I was scared. And
Right.
so the fact that he saw that and he allowed me to just, he knew it was time. He knew it was
Right.
time for me to go. um I mean, I have so many, and we could just have a podcast about like
Right.
amazing NIH stories, frankly.
Oh my,
But yeah, and it's 100% true. I will always remember that.
yeah, absolutely. I do want to remind our listeners that we do have Jayla Barnes, who's been on the podcast before. She's a palliative and hospice specialist who does a monthly online group called Pull Up a Chair through the Judy Nicholson
Mm.
Foundation, and that is for caregivers. We do allow patients to be on there too, but it's primarily a caregiver focus, just a Zoom support group that happens.
Oh,
It's free
that's great.
month.
That's
And so,
wonderful.
yeah, I just, want to gentle plug that because I know we're talking about a lot of, really deep, heavy stuff right now with, especially as it relates to caregivers and taking care of yourselves. And so just to make sure that our listeners remember that we do have Jayla's, a monthly group
It's
that meets.
wonderful.
Yeah, and that can be found on our Facebook and also on our website. So, yeah, I think, Tracie, to your point, like there is so much focus around the patient, which I mean, makes sense, right?
Yeah,
As it should
there should
be.
be. Yeah.
But, I remember one thing that my late oncologist had shared with me early on was like
Mm.
you've got to have support around you. You have to have your family and your friends, and that's I mean that impacts patient outcomes, quite frankly, right? Is making sure that you have that support group around you. And so I think that it's another great reminder that, whenever a caregiver takes the time to recharge their batteries and that they have their support, too, it helps you be a better caregiver. It helps you to be able
Yeah.
to have the stamina and the energy to be there for your patient.
Yeah. Totally agree. And it doesn't have to be like an or. It's not like gets
Yeah,
attention toward the patient with cancer or the caregiver. It can be
right,
an or, right? And I think that
right.
that's really hard as a caregiver to even think of that, but I've learned over the time that it's important. And I think it's hard when with what we have, and the fact that our treatments, like when it was the first surgery, there were so many people around. And then the second it gets, and then by the third and now the fourth, people think like, oh, well, it's just sort of, I'm like, it's still cancer surgery, everyone. It's like it's still a big thing. And it doesn't necessarily get easier. People think, oh, let's get easier. You understand more about what's happening, and now I have a community at the NIH, which is helpful, knowing the nurses and the doctors and where to go for my favorite coffee in the morning and what time they open and those kinds of things. But it's still hard, um even if you've done it before. So I think that's a kind of a message, like that it's okay that it's still hard. It's still cancer. It's still watching your loved one have to go through something. It's still a major disease and major illness, even if, or if you've been on systemic for a long time and you're having adverse events, it's still hard.
Yeah.
And it's okay if that's, going on for a period of time.
Yeah, it's true that, in the beginning that everyone's around, you're getting flowers delivered and, casserole
Food and
delivered,
yeah,
right? Yeah. And and I get it. Like if you're not living it day to day, you go, oh yeah, like, oh, that's right. You had cancer a few years ago, right? And you're like,
right,
no.
right, yeah.
Um,
While you're
but
doing all your scans and
right,
you're
yeah,
reliving it
yeah,
as
it's
frequently as
hard.
you have the scans, and yeah, it
Yeah,
doesn't just go away.
right.
Um,
Yeah. And I feel like I have I feel guilty sometimes whenever I get scan anxiety because I'm like, man, I have it so easy compared to so many patients that
we all
I
think
know,
that, I
much
know.
less the ones that I don't, right? But I have to remind myself this is still like this is still scary that every, few months I go and get a scan and I don't know if it's gonna turn my life upside down or not, right? And
Yes.
that's okay for me to acknowledge and feel that fear, and it doesn't take away from another patient and what they're going through.
Yeah, I think we all feel that kind of, because I feel really grateful that, there is no systemic therapy for what my husband has, but I feel grateful we're able to handle it with surgery, that he doesn't have all of these side effects that are possible from systemic, and that he's able to live a normal life outside of the surgeries and recovery. And so that sometimes I even feel guilty for being like, why am I so upset about this? At least he's, so I think we all have that. And I think finding gratitude, that's my other tip. Find gratitude, because that really helps to center you. And it's very hard to be anxious or have anxiety and have that coexist with gratitude. Or try it. It really doesn't happen. And so find gratitude, because there are things to be grateful for. While you're going through it. And I really think that helps. And that was advice I got really early on. And I was like, okay. But it really does. I know it sounds very, I should be doing like yoga next, but it really helps. So I just keep thinking of all these tips.
Yeah, it's funny. I say a lot of times that I hate the way that I've met wonderful people like you and, other friends that I've made in the community. It's the worst way to meet the best people, right?
For
Um,
sure.
I wish we could have bonded over like, I don't know, a video game or something, right? But
Yeah.
I'm not grateful that I had cancer, but I am grateful that if it had to happen, it's connected me to some people that I wouldn't have otherwise known. And I can't imagine my life without, and so
I completely agree. I completely agree. I think too, when my husband was first diagnosed, I remember thinking, like, we're never going to have joy again. Like, that was a very big fear. Like, how could you ever have joy again? And
right,
talking with a friend who was a caregiver for her husband, she said, there will be joy again. I
right,
promise you, there will be joy again. And along this journey, there will be things that happen that are amazing, that you would never have expected in a million years would have been part of the journey. And she's right. And meeting the people like you mentioned, and finding the head of the urological oncology branch bring you articles on a Sunday night, and the nurse anesthetist who realizes that you're done, and grabs you and just holds you and gives you that kind of, I mean, those are like the pieces along the way that you just sort of never think of. And people coming together for you, and like the kindness, and um yeah, but I think that's important to know, that there is more to this journey than just the obvious sadness and anxiety and stress.
right.
Like, there are other things too. And I think that's where like the gratitude piece comes in.
Yeah, yeah. I think a lot about and I wish I could remember her name. I don't anymore, but after I had my nephrectomy, it was like maybe night 2 or 3, and I was just like, I couldn't sleep. I was starting to really, feel the effects of the surgery, and I also was like just really itching badly from like all the painkillers and all. I just like
Yeah.
couldn't get comfortable, and it was the middle of the night, and it was an ICU still. And my family had already gone for the night. My husband was sleeping on the couch in the recliner in the room,
Oh,
and
I
the
know it.
night nurse
Yeah.
came in. Yeah, and the night nurse came in to check on me, and I was like, she's like, oh, you're awake, like it's like 2 in the morning, whatever it was. And I was like, yeah, I can't sleep. And I'm like, I still had the NG tube down my, which was
Mm.
super uncomfortable, and I couldn't drink anything. I was like, I'm like, I'm dying from thirst, and I was like, my back's itching. And she literally sat on my bed and like scratched my back for me. And I remember I started crying, and she just was like, just like patting my back, and she's like, it's gonna be okay. It's gonna be okay. And you know, I'm sure she had plenty of other things to do that night, right? And
Yeah,
she probably doesn't even remember that interaction
that's
8
right.
years ago,
But what it,
but
yeah,
I do.
what
I
you
do.
do.
And it meant
Yeah.
a lot to me because it really was at that point where, like,
You
the
just
middle
needed
of the
some
night,
comfort. You needed some
right.
compassion.
Yeah,
Like you just
exactly.
needed to let it out. Yeah.
Exactly. So, well, Tracie, thank you so much. Are there any last thoughts or, words of advice? You've already shared so many, but anything that you really want to leave our listeners with today?
Well, thank you for having me. Thank you to the Judy Nicholson Foundation, the sponsors, for doing this real talk on renal cancer. I think it's so important. I guess my kind of mantra is bilateral multifocal kidney cancer focus on renal preservation. And if you are at a place where they're talking about taking out both of your kidneys, which happens all the time,
Mm.
find the Judy Nicholson Foundation, find Casey Cure, find find an advocacy group, find one of us, and we'll help you get to a place to have another opinion. So don't take out kidneys unnecessarily. That's always my parting sentence. Stop taking out kidneys unnecessarily.
Great advice.
That and find gratitude.
Yes. Yeah, I completely agree. Tracie, this has been an absolute pleasure. Thank you again for being on the podcast. And once more, I'm Laura Esfeller. I am happy to have the support from our sponsors. And also, again, you can find out more on the Judy Nicholson Foundation's website, and we will see you next month. So thank you.
Thank you. Bye.